Delivering high-quality healthcare across a sprawling rural region is one of the toughest challenges in medicine. But WVU Medicine has done it, building a 25-hospital network that delivers advanced care in communities across West Virginia and beyond. In an era of workforce shortages, reimbursement pressures, and rising patient expectations, WVU Medicine stands out as a model of how to grow, sustain, and innovate in rural healthcare. Welcome to CareTalk Executive Features, where we spotlight leaders transforming healthcare from the inside out. I'm David Williams, president of Health Business Group, and my guest today is Albert L. Wright, Jr. He's president and CEO of the West Virginia University Health System. Albert, welcome to CareTalk.
Hello, David. Thank you for having me today. I'm excited to be here.
Outstanding. Well, you spent your career in healthcare leadership, and I'm wondering, what drew you to that field in the first place? And how did the path that you took lead you to WVU Medicine?
I'm a pharmacist by background, and when you're young and you're looking at different opportunities, nobody at a young age says, "Hey, I want to be the CEO of a large academic health system." That just kind of happens over time. So I'm a pharmacist by background. I worked in small hospitals to start, and over time, I became very interested in some of the hospital operations, some of the quality aspects that I was involved with, and wanted to become a hospital pharmacy director, which I did. And then when you work in small hospitals, you wear lots of hats, and I started to run some different departments over time. Whether that be imaging or the lab or whatever the case may be. And the widgets are different, but the working with people, managing budgets, working with medical staff is the same. And my career kind of grew into more general administrative functions over time, and now I have the privilege of being the CEO at a large rural-based healthcare system. That is, and I've been here a little over 11 years, and it's a spectacular place to be.
Yeah, that's good. My co-host sometimes talks about his career path and going up the ladder kind of as you had. And he described it like a pie eating contest. He said that, you do this thing and you do well. And what's the prize? A bigger pie and less time to eat it. Is that a fair characterization?
I think that's fair. I think, and those of us that are successful learn that as that pie gets bigger, you need to surround yourself with really brilliant people and complementary partners to help you make a bigger impact in time. And that's what I've certainly been able to do.
That's great. The organization has actually grown a lot under your leadership. So it's not just that, they needed someone to do it and you managed to fill those shoes. But so what's been your guiding vision for the role of the system in serving the region where you operate?
It's our health system has an interesting history because we were formed by an act of the state legislature in 1996. And there was a concern by the legislature at that time that a lot of West Virginia hospitals were being purchased or acquired by for-profit out-of-state entities. And there was a concern that if we did not have a West Virginia-based headquartered health system, that those out-of-state entities might not make decisions that are in the best interest of West Virginians. And so the goal of our health system, and we have a twofold mission. One is to improve the health trajectory of the state of West Virginia and the surrounding areas we serve, and two is to really carry out the teaching objectives of West Virginia University. So our growth has been really about making sure that we're of a size, scope, and capability to care for West Virginians in our surrounding areas, and that we're always going to remain a West Virginia-based, headquartered, organization. So we've really focused on having a robust continuum of care, primarily based out of our 890-bed academic medical center here in Morgantown, but simultaneously a population health footprint that covers the state and spills over into border states. So, I always share, when you're any organization you run or operate, you really want to be focused on growth and or excellence, and preferably both. And that's been kind of the approach we've taken.
Those of us who are active in health policy hear a fair amount about West Virginia. There's been, a place where there's been a lot of attention, special attention to some of the populations that are there. I'd love to hear from your standpoint a little bit about some of the communities that you serve. What makes those populations maybe in any way different from just sort of like, the average in America, and what you do in terms of building trust and building those relationships in
Yeah.
those communities.
That's a great question. So, I like to level set by reminding everyone that West Virginia is the only entirely Appalachian state in the country. So every county is Appalachian, and our largest city, Charleston, has I think 49,000 people. So we really don't have population centers. So when you look at West Virginia, I could make the argument that we're the definition of rural healthcare. And so, one of the things I think we've done differently as a healthcare system and that I'm proud of is we've really focused on having access around the state, because you can't just have one major health center and have everyone come to Morgantown. This is it's a very large and spread out state, and it has really rough terrain. When you hear that song Country Roads, these are literally country roads, and they go up and down and all over the place. So in our operating model, our hospitals survive on their own bottom line, and we've become really good at having stable and financially viable hospitals around the state and clinics associated with those hospitals. 9 of our 25 hospital sites are critical access hospitals, and we're very proud that we've been able to make them work. And in our operating model, where we really push services out into those communities, I'm very proud of the fact that all of our hospitals and acquisitions are financially viable. We've grown clinical services in all of them, and we've significantly, always, but sometimes very significantly increased the employment in those local communities as well. And those hospitals are economic drivers in their communities. They're usually the largest hospital in the community, and we have community boards at every, uh, you know, fiduciary boards at each of our hospitals, which I think has ingrained them in those communities.
Are there any characteristics of the population? Let's say if we look relative to the U.S. average, people different. Does that have any impact or on your strategy?
Yeah, our population has, some significant challenges in a lot of social determinants of health challenges, a lot of behavioral health challenges. There's a lot of people that live, financially challenged around the state. So, we've really tried to focus over time, how do we start to put some resources? How do we increase our number of value-based care contracts, and or we can talk a little bit about our provider-sponsored health plan, Peak Health, later on if you want. But how do we start to incentivize ourselves to start to correct some of these challenges people have around social determinants of health or in-home monitoring, so that we can really meet people where they're at?
It's really intriguing to hear, and it's encouraging that each of these individual hospitals is actually viable in its own right. It's not what I would have necessarily guessed from the outside. And I'm wondering what sort of strategies you've been using to make sure that patients can have access to world-class care, close to home. You mentioned you don't
Yeah,
just have to come to this big
yeah,
magnet.
yeah,
It's
yeah,
not just designed to
yeah.
draw everybody into the main facility.
Yep. Yep. Yeah, the main facility, believe it or not, is overly full all the time. So we're incentivized to keep people out in the communities, and we call that our breadth and depth strategy over time. So there's a couple things we've done, I think, that are neat um, to help spread that access around the state. One is we are heavy investors in our electronic medical records. So we use Epic in every clinical setting we have. So small clinic to urgent care, to small hospital, to big hospital, and back to home health, so that everywhere a patient goes, their images, their labs, their prescriptions, their physician progress notes follow them, which allows for us to really have robust population health management strategies and coordination, around the state. The other thing that I think, we've done well, that we probably don't talk a lot about, is over the last decade, we really transformed from an academic medical center to an academic health system. And what I mean by that is, in many, many cases, our physician chair leaders of our academic departments, neurology, cardiology, hematology, oncology, they have their faculty here at the academic medical center in Morgantown, but we have faculty now spread throughout the state. And, that has really allowed us to increase our access around the state in good coordination when folks have to come to the academic medical center for higher levels of intervention.
When I think about rural healthcare and rural hospitals in particular, they face a lot of the same barriers, but also some additional ones compared with
Yeah.
a hospital in a suburban or an urban setting. And I'm thinking about, workforce, transportation, you already alluded to, chronic illness, other social determinants that you alluded to, and just the overall economic constraints. You're not going to be able to change the entire state. Certainly not. Maybe they could change the economy easier than the geography. But how do you adapt your strategy to overcome those challenges? And from what you do, are there lessons that others in other rural areas or regional systems could learn from, do you think?
Be more specific, David. What exactly are you asking for?
Yeah. So what I want to know about is let's take this issue about chronic disease.
Yeah. Yep.
And so you've got, on the one hand, I get chronic disease. Maybe I want to be seen by a specialist.
Mm-hmm.
They're not going to come to Morgantown. Even if they did, it's going to be busy. There's a limited number of physicians that are there. How do you help somebody with a serious chronic illness in a rural area to have good quality of life, good outcomes, and reasonable cost?
Gotcha. First thing is you have to make sure that you have access points for them to get into the system, right? And so whether that's through small hospitals, whether that's through our clinics, we've taken an approach where we have to really blanket the state and make sure we have access for folks all around the state. I do think, one of the advantages we've had by tethering people to the academic departments, we've had much more success in recruiting great physicians and caregivers, advanced practice providers around the state. People are more comfortable to go to rural parts of the state to provide care and live there and work there if they know that they're going to have, being part of something larger. And in West Virginia University is a significant player and a brand that people trust and feel good about. The other thing that's been helpful in our population health strategy and allowing people access to subspecialists is there aren't a lot of silver linings that came out of the pandemic, but one of them is the comfort people have with telemedicine, not only from a patient standpoint to say, hey, I'm able to look and interact with my physician, but from the physician standpoint that it is very feasible and viable now for a physician in Morgantown to be in a traditional clinic seeing 3 or 4 patients in person, then to go in an exam room and see a patient from Princeton, West Virginia, which is in the southernmost part of the state, and then see a patient from, outside of Wetzel County, West Virginia, which is on the far west side of the state, and have robust conversations. And with that interoperability of the electronic medical record, still be able to see all that information. So in many of our chronic diseases, our endocrinology department is one of the best at this. They're seeing patients all the time, and a high percentage of those visits are telemedicine wise. We've done that a lot in our pediatric subspecialties as well, where pediatrics is a numbers game, and kids with different types of disorders where they might need to see a neurologist or a cardiologist or an endocrinologist. It's not realistic to put those providers in every part of the state, but having virtual visits like the conversation you and I are having right now have been a very effective tool in our toolbox.
Talk a little bit about what you do on these, social determinants of health. Like, what would be an example of something? People talk about obesity, smoking. There may be some other factors, poverty, whatever it may be. What are some of the main factors that you look at, and how do you deal with them beyond? We talked on the one hand subspecialists. Now this is kind of all the way on the other side.
Yeah. So how do you, your clinical health is only, one component of your total health, and a lot of the environment that you live in, affects your care. So I'll take it from two angles. One is kind of directly what we're doing with patients today, and one is what we're indirectly doing to help give younger people here in West Virginia a brighter future, in my humble opinion. So when you look at existing families with social determinants of health, and we've got a pretty robust population health management group, about 200 people working in that department now, and I don't even know how many patients are following these days. But that can be anything from making investments in transportation, which is a real big deal of how do we get people where they need to go, for medical care or wellness or whatever the case may be. We made investments in food insecurity in some cases. We make lots of investments in home care. How do you modify people's homes that allow, whether it's easier access or ramp access, whatever the case may be. We're also making some significant investments in home monitoring, David. There's a lot of things we can do now from the home where we can monitor your cardiac situation, blood pressure, atrial fibrillation, your blood sugar, your weight, whatever the case may be, and how do we monitor you from afar before you end up coming back to the emergency department? The other thing we've really incorporated is a lot more in-home visits. So we also have a really robust home care division now that covers probably 35 of the 55 counties around the state, where we can easily have someone drop in to see you. And you can learn a lot about, and I don't mean this in a judgmental way, but you can learn a lot about a patient when you visit them in their home and see the challenges they're facing, to help learn of how can we make interventions that will keep this patient at their optimal state. Now, let me flip a little bit. The other thing we're starting to do more and more is what we call our med ed program, where we actually have high schoolers working in our hospitals as part of their high school rotation. We do that as a partnership with a group called the Education Alliance. And we're really trying, whatever environment, David, you grow up in is normal to you. And if you grow up, and we have a lot of homes that have challenges. We were hit hard with the opioid epidemic here. We had a lot of kids that lost their parents, and we have a lot of kids that grow up in houses where there aren't people that are working, or there aren't people that are eating well or smoke. And how do we get those kids into our hospitals, help them to learn, what it's like to have caring adults in their life, make sure they have caring adults in their lives, help them make better choices on what they eat, what it's like to have a job, and help to realize that, hey, if I have a job when I come out of school, my life's going to be a lot better than if I don't have a source of income. And, we have one of the most challenged workforce participation numbers in the state. I think we're at 51% of people that can work do work, and West Virginia gets a lot better if we get that number up and more people employed and improving their lives.
That makes sense. Now, based on the work that you've done there, do you get other rural or regional systems coming in and asking you for advice, or sharing thoughts with them? And what are the kind of the topics that people like to discuss?
I think rural healthcare is a sexy topic these days. So a lot of people are talking about rural healthcare, and I remind everyone that past success does not guarantee future success. So we never want to get too big for our britches. But I am trying to be a constant voice to remind folks that rural healthcare can be tough, but you can make it work, and you have to be committed to making it work, and you have to make investments. And we're a nonprofit organization. I shared our mission earlier, and so I'm still waiting for the affluent West Virginia hospital to come join our system. They're all struggling, and that's why they join. And our job is to help them get on their feet and do well. And so I think people are paying more attention to that. And we've had a number of calls of folks, or I'm get to speak on some panels once in a while. And I think the message is rural healthcare is tough, but we have to be committed to these populations, and we have to find ways to make it successful.
We discussed this topic a little bit before, but I want to come back to it, which is about recruitment and retention of your top clinicians. So
Hmm.
you mentioned, first of all, tying people into their academic departments so they could feel
Yeah.
comfortable living there. You've got, telehealth and so on. Do you have an overall kind of playbook for attracting and keeping great physicians and nurses and specialists? And think about, yeah, there's a lot of demand for such people all over the place. How do you compete?
Yeah, it is historically, unless you have a tie to the university or the state, most people aren't waking up on both coasts and saying, how do I get to West Virginia? So, when we get them here though, I think they realize, there are a lot of spectacular things here. There's great places to, it's a great Morgantown itself is a great college town, great places to eat, great culture. We've really, if you look at our academic medical center a decade ago, really looked like Big General Hospital. It now looks like a collection of 6 or 7 subspecialized institutes where we've really done a good job of putting people, programs, and physical plant in one place, whether it's heart and vascular, the neurosciences, cancer. And I think it's shown, David, a commitment to doctors that, hey, this place is really committed to what I do for a living. We just built a beautiful new children's hospital. And if you're a pediatric subspecialist, you want to be at a place that says, I'm very serious about, pediatric subspecialties. So that has helped us. I'm biased. I also think we have a spectacular culture. Every CEO is probably going to tell you they have a spectacular culture, but that's helped us, recruit, greater than a net new 1,000 physicians to Morgantown over the last decade, and we'll continue to do that. And we already talked about that. How do you get them out into the communities where a lot of these subspecialists now live in our what I call our regional 200-bed hospitals, but having them tethered to the academic medical center really, I think makes it psychologically safe for them to come and work in those communities. And some of those communities are beautiful. I mean, one thing we do have in West Virginia is beautiful outdoor recreation and a beautiful state. So a lot of folks fall in love with that.
You've described this maybe, but I don't know if there's anything you would explicitly say about the culture, any particular attributes of it that you would describe when people say, what's the culture like? Is there a way that you would describe it or someone would describe it?
I don't know that I have a specific way to describe our culture. I have found though that tying everything back through our mission to improve the health trajectory of the state, we always think about our decisions through those lenses, which I think we all do, from myself and our leadership team and our board of directors. I think people, I think we have a healthy mix of folks that are from West Virginia, obviously, especially in the medical staff that love the state. And I'm not from West Virginia. I will tell you, though, people in West Virginia, from West Virginia, love West Virginia more than other people from other states do. So there's a great pride there. And we've done a good job of making sure we recruit physicians that come in that maybe aren't from here but fit that culture, and it's fun to see good things happen to a population that in a lot of ways has been forgotten about over time. And so to do good things and to start to put infrastructure in place that someday hopefully takes West Virginia from a population that, depending on what metric you look at, heart disease, obesity, diabetes, drug addiction, sense of purpose is historically 45th to 50th. As we put in generational change to make this a top quartile population with top quartile health outcomes someday, that's easy to get people excited about.
Yeah, no, that's great. So we've been talking about a lot of the successes, and at the other, the on the other side of things, we're sitting here in late 2025.
Mhm.
All hospital systems that I know about, health systems more broadly, are feeling a squeeze.
Mhm.
If you're immune, let me know. But I wonder what some of the big challenges are that you're facing and how you're looking at steering the organization through a time like this.
Yeah, great question. So, we're doing well, in sustainably well, not spectacular to the point where we can put it on autopilot or anything. And in the healthcare system financing, is, any way you look at it, is kind of held together with toothpicks and bubblegum, and it's put together with a patchwork of, federal programs around 340B or, DPP payments and different things. But we've been able to make it work, and we've been able to thread a needle which allows us to continue to grow. Not only growth in acquisitions and the number of entities in the health system, but we've truly grown access around the state significantly. The number of patient visits we have, our board has approved about $1 billion in new strategic capital investments in the last 2 years. So we've got building projects going on all around the state to keep up with that growth. And we've kind of had to thread the needle with, growth and meeting our mission and staying in good financial order to keep our bondholders and investors, and our rating agency satisfied. And we've been able to maintain our rating agencies, our ratings for the last decade while we've done that. So we've been pleased. We could hoard capital hoard days cash on hand and try to get a better rating, but that would be inconsistent with, the investments we're making to improve our population. So like I said, past success does not guarantee future success, but right now we're managing it. We're obviously watching the changes through the one big beautiful bill, and obviously that will hurt, I think, a lot of folks, especially with high Medicaid populations like the one we have. So I'm hopeful that there's time for advocacy and maybe some changes to make sure we don't have people lose their health insurance in the future. So we worry about that like everyone else does, but we try to keep checks and balances to make sure we're moving forward.
I guess there was some awareness in the one big beautiful bill that rural systems would be hit hard, and this rural transformation fund with $50 billion, which sounds like a lot of money, until you start divvying it up and seeing what your share is and what it's supposed to make up for.
You just hit the nail on the head, David. I think it's important for people to realize that the $50 billion, well appreciated, we never turn anything away.
Yeah,
is not going to be sufficient to cover the losses if these Medicaid cuts went through.
Yeah, that's right. So we've talked about some of the successes that you've had in bringing advanced medicine to underserved population. Are there specific initiatives or programs that would stand out to you if someone's listening here and saying, hey, I've got either a rural system or another system, we've got challenges in terms of population health? Anything you might encourage people to look into and possibly replicate?
A couple things, and I think this just kind of goes hand in hand of really, building the system out the way we have. And it's interesting because most systems of our size and scope, we're a little bit over a $7 billion in net revenue system. So we're not the biggest, but we're a good size. Most systems like ours are built around urban settings of, with 2 or 3 million people. So everybody can kind of drive to the big hospital or the hospitals in those urban settings. One of the things I think we've done that I think is neat and that others should consider is there are a lot of things you can do in these more remote hospitals. So, I was reading the other day, I won't name the system or the city, but I was reading a newspaper in another city, and they were bragging that their academic medical center had just started to do these Alzheimer's antibody infusions, and I called our physician that leads the Rockefeller Neuroscience Institute, and I said, aren't we doing that in Wheeling and Princeton? And, and he's like, yeah, we started doing that like a year ago down there. So, and the same thing with clinical trials. Like we have, our cancer clinical trials from our WVU Cancer Institute. We've got almost as many clinical trials going in these remote sites that we do in Morgantown proper. And so, why if a patient gets cancer in Parkersburg, West Virginia, or Kaiser, West Virginia, why shouldn't that patient have access to the exact same clinical trials that you get if you live in the academic medical center county? So I think just being committed to, now you can't do everything everywhere. We can't do heart transplants in all of our sites. We do that in one site. But for the things that you can do in multiple sites, especially for a rural population, I think health systems should really be open-minded about trying to do these things in a safe fashion as we can. And we make sure the protocols and the physicians working at the sites are all the same. But, you can do a lot more in rural sites than people realize.
Albert, up near the top of this episode, you alluded to the fact that you started a health plan a few years ago. I would love to hear a bit about what was the motivation for that, how well it's panned out, and how we think about, it's like you pay yourself, sounds good, but I'm sure it's not quite as simple as, as that.
Yeah. Starting a provider-sponsored health plan is not for the faint of heart. It's something you have to be committed to. And here's why: is we spent a few years trying to figure out our operating model, and I believe, our board of directors believes, and our leadership team believes, that you can never truly improve outcomes and lower costs until the people that pay for healthcare and the people that provide healthcare are financially aligned, right? And you're trying to do the same thing. Because if you're fighting over what you want to do to someone and somebody's fighting over are they going to pay you for it, you just don't get anywhere. And so we started our own provider sponsored health plan with two other health systems. We operate Peak Health. Our partners are Marshall Health down in Huntington, West Virginia, and Valley Health in Winchester, Virginia. And those are two kind of like-minded organizations, and they're owners in Peak Health as well. And so what we've really tried to do with Peak Health, and David, this really leans back into those conversations we had earlier about making investments in the social determinants of health, behavioral health, home monitoring, screening, is we've set Peak up a little bit differently than I think other traditional provider-sponsored health plans, because we're not the first organization to ever create our own insurance product. But a couple of things we're doing differently. First off, we're processing claims in Epic as well. So we've got complete real-time visibility and interoperability between payment and provision of care. So you know exactly what's going on everywhere all the time, which allows us to intentionally decrease administrative burden, the back and forth between healthcare providers and healthcare payers. So we're decreasing administrative burden there, one. Two is we're treating Peak Health as a cost center rather than a profit center. And hopefully that breaks that historical fighting between the payer and the provider of who's going to get the dollar, right? In our case, Peak exists as a cost center to support the health systems that own it, and any profits go back to the health systems. So what that allows us to do, David, is really create neat alternative payment models. So when Peak, let's say for our Medicare Advantage population, Peak gets all those dollars on January 1st of the year. I'm being blunt for impact, but gets all of those dollars on January 1st of the year, and it hands the entire dollar amount over to the health system as payment in full for that Medicare Advantage population. And what that does for the health system now is we are completely incentivized to keep people as healthy as possible and in the lowest cost setting to maintain our financial viability. And when you're incentivized to keep people as healthy as possible and in the lowest cost setting, you start to make investments that keep them out of the ED and out of the hospital whenever you can, and very consistent with those investments we talked about earlier around the social determinants of health and those types of things. So we're only a couple years into the journey. We're making some progress, but I think we're laying the financial alignment and infrastructure to hopefully do really cool things in the future.
Well, it sounds compelling, and I know it's not for the faint of heart, so we won't frighten anybody with some of the scary details. But congratulations on getting that going. Now, of course, I don't expect that these payment models and delivery systems are going to just stay the same. So when you're looking ahead, what do you see as coming next? What's on the horizon, and will it be something where the patients see the impact?
I think we don't know exactly what tomorrow looks like, but we, as a health system, we want to be as flexible as possible and have the infrastructure, whatever our future payment models and mechanisms look like. I do think over time, if we're successful on our journey with Peak and the things we're trying to do, I always equate it to the iPhone. And there was a time when I had a computer and I had a camera and I had a phone on the wall and those types of things. And now you have this little device that you carry, in your pocket that has all of that. If we're successful in Peak, from a physician standpoint, they shouldn't. It should feel a lot easier to take care of Peak patients and a decreased administrative burden than if they're working with outside payers. And same from a patient standpoint. If we're successful, people aren't thinking that I have health insurance and I have a healthcare provider. They think they have an entity that is lightning or laser focused on keeping me as healthy as possible. That's where we're trying to steer this ship to.
Yeah, that's a great vision. I know I would like that as a patient, so hopefully it could be achieved. Well,
we're working on it.
Yes, good. Well, that's it for another episode of CareTalk Executive Features. My guest today has been Albert L. Wright, Jr. He's president and CEO of WVU Medicine. I'm David Williams, president of Health Business Group. If you like what you heard, I hope that you're going to subscribe on your favorite podcast platform. And Albert, thank you for joining me today and for all that you're doing.
Thank you, David. I appreciate the opportunity.